Thank you to UCB for generously sponsoring this episode of Dermatology Undressed, a provocative podcast. UCB had no influence on the selection of the faculty nor content development. This podcast is for educational purposes only and is not medical advice. For personal medical care, please consult a qualified healthcare professional. Welcome to Dermatology Undressed, a provocative podcast. I'm Dr. Lindsay Ackerman, and today we're talking about psoriasis, inflammation in the skin you can see, and its link to heart disease, which you can't. I'm distinctly honored to be here today sitting in studio with someone that most professionals in our field would agree is among the most, if not the most, influential pioneers in defining and defending how skin signs reveal internal consequential pathology. Dr. Joel Gelfand is a dermatologist and epidemiologist at the University of Pennsylvania in Philadelphia, Pennsylvania. He currently serves as the James Layden Professor in Clinical Investigation, the Vice Chair of Clinical Research, and the Director of the Psoriasis and Phototherapy Treatment Center, and the Medical Director of the Clinical Studies Unit in the Department of Dermatology at the Perelman School of Medicine at the University of Pennsylvania. His academic lineage hails from a long line of esteemed institutions, including having received his bachelor's degree from Tufts, his medical degree from Harvard, and having completed his residency in dermatology and master's of science in clinical epidemiology from another Ivy League institution and my alma mater, the University of Pennsylvania. In addition, he pursued both pre- and postdoctoral fellowships in dermatology and epidemiology. Dr. Gelfand's pioneering work, which arguably has revolutionized how we approach patient care, has been focused on the connection between psoriasis and cardiovascular disease. Thank you so much, Dr. Gelfand, Joel, for joining us today.
It's a pleasure to be here, Lindsay, and really looking forward to having this conversation with you.
This is an absolute delight for me to be sitting with you in studio, Dr. Joel Gelfand. Thank you so much for making the time to be here. You've really revolutionized what dermatology is, what it means to our patient population, our other healthcare professional colleagues. And I want to welcome the floor to you and say thank you first for what you've done, what you continue to do for our field, and allow you to introduce yourself to the audience.
Yeah, well, thank you, Lindsay. It's a very kind introduction and very humbling, of course. I feel very passionately about dermatology, and it's funny, like a lot of people, when I was in medical school, I didn't know what dermatology was. I actually skipped the classes on dermatology. I probably shouldn't be saying this.
Yeah, you probably shouldn't be saying
now
this.
Now that I know this. In the second year, because I was busy doing some work on healthcare policy reform. And when I took an elective in medical school, thinking I might do general medicine, I just fell in love with it. And one of the things that really taught me how powerful this field is that I met a young man in high school, probably about 16. He had a condition of his face called keratosis pilaris. For people who don't know, it's basically makes the skin look sort of red and a little bit pimply. And he asked me, would he grow out of it? How long would he have it for? And I didn't really know. I was a medical student, so I tried to buy for time. I said, well, why do you want to know? He said, well, this doesn't go away. It's going to affect what career I choose. That, I'm not going to work with the public because I'm sick of people telling me I look like I'm drinking alcohol or things of that nature. And that was very powerful to me because I think many of the diseases we treat in medicine are on the inside, and people don't need to know that someone's suffering with diabetes or Crohn's disease or arthritis, what have you. But when you have a visible skin disease, you can't hide it from the world, and it's often extremely stigmatizing for people. And it's a powerful way of trying to help people. So that's where my interest in dermatology came from.
And I want to pause and just say that that's like anything but cosmetic.
Mm-hmm.
I mean, that actual condition that the 16-year-old boy had, who's confronted with what does my future really look like, is talking to you about quite literally what's the trajectory of his life going to be. Mm-hmm. Can he do all the things he wanted to do, or does he actually have to sort of deviate and do something that's going to be much more insulated from the public scrutiny or potentially the visibility of his disease? So there is most definitely this part of dermatology that is where skin interfaces with the world, right? Mm-hmm. Both environmentally, right? A lot of skin diseases might be made worse under certain environmental circumstances because our skin touches everything. Mm-hmm. But really, it also, touches people's eyeballs. People see you're wearing your disease quite literally on your sleeve, and it impacts our patient population tremendously that struggle with the visibility.
I think it takes a special kind of courage to face the world with a sort of stigmatizing skin condition.
Absolutely.
And in our society, if you God forbid have a cancer, we view cancer people as battling cancer and as heroes and whatnot. But many people who live with skin diseases sort of suffer in silence. And I think the things like this podcast are really helpful because the most important thing we can do is sort of help get rid of myths, misunderstandings, falsehoods, what have you, and build better understanding and empathy for people, no matter what issue they're dealing with.
Yeah, I appreciate you saying that very, very much. And I mean, this is so not the focus of what we're talking about, but I'm so glad you're bringing it up because it's actually the foundation of our entire profession. Is we have to first and foremost understand patients are living with the diseases that we have to manage. And they may be looking at something and worried about something, right? They're worried about what their future career might be because they're publicly going to be scrutinized about what their appearance is living with this condition. And then our job is to appreciate that, to understand it, to be empaths, if you will, but at the same time also recognize what that disease could even be telling us about what's going on the inside.
Yeah. So I'll tell you, this is how the idea of psoriasis and heart disease got in my brain, which is that when I was in medical school, our medical student dermatologist was a guy named Thomas Fitzpatrick, who was a very famous dermatologist. He's now deceased, but he wrote a very famous book called Dermatology and General Medicine.
Yep.
And
by the way, in medical school, that was my favorite book.
Yeah, right, yes. And so he liked to be called Fitz. And so he was examining me and talking to me. And I said, Fitz, why did you name this book Dermatology and General Medicine? So I was a little bit of a skeptic. This before I knew much about dermatology. And he said, Gelfand, he liked to call people by their last name. Yeah. He said, Gelfand, I want people to understand that dermatology is a serious specialty of medicine. And that many skin diseases, many internal diseases could present on the skin. So for example, people with thyroid diseases could develop skin findings. For example, it's a classic example. Or people with vitiligo could have underlying health problems that are associated with it. And so when I started learning more about dermatology and learning more about psoriasis in particular, I thought, maybe skin diseases could potentially present internally. And it didn't make much sense to me at that time, this is now the 1990s, mid to late 1990s, that someone could have, a major organ, in this case the skin, inflamed, for decades with no internal consequences to that. It didn't make any sense to me.
Yeah, and you're right. You're absolutely right. And that curiosity is what has literally put you at the forefront of our field in not just repositioning where we sit as a subspecialty of medicine, but offering such a profound benefit to our patients, to the public, in a forum like this, where we can tell patients flat out, if you have severe psoriasis and you're 30 years old, you have threefold likely of a chance to develop a heart attack.
Yeah.
I mean, that's pretty outstanding evidence.
Yeah, I think that, before I get into the numbers behind this, I want to talk a little about how I started thinking about the connection to these two things. So then in the early 2000s, there was an article in New England Journal of Medicine, one of our major medical journals, and it was a cartoon explaining the inflammatory nature of atherosclerotic cardiovascular disease. And it's a cartoon, and it was just like the cartoon I was studying on the boards of the immunology of psoriasis. And so that was a little bit of a eureka moment. You sort of have two diseases that look like they have nothing in common, but it turns out they have a major thing in common, which is chronic inflammation. And that triggered the idea in my mind that this is something we needed to study more. And through my training in clinical epidemiology, basically that science is interested in the study of people, and it's interested in trying to understand and quantifying how much an exposure and outcome are related to each other, in this case, psoriasis and cardiovascular disease. And I was fortunate at the time to be at the University of Pennsylvania, where they were really pioneers in using what's called big data, large electronic medical record data sets. Now, for those who are who do research in this area, it seems mundane. Everyone has access to large data sets, but in the late 90s, early 2000s, this was actually a very unusual thing to be able to do. And in the United Kingdom, they had started adopting electronic medical records in the 1980s, believe it or not. And the United Kingdom has always been very engaged in observational research, clinical epidemiology.
Population health.
Right. And do they do it in a very rigorous way. And so when they developed their EMR systems, they spent a lot of time to validate that they actually were accurately capturing the conditions people were being treated for. And the system we used, the clinicians were incentivized and tested to make sure when they said someone had a code for psoriasis, they actually had it. Or if they had a code for a heart attack, they actually had, the signs of a heart attack, like they had, the abnormal enzymes in their blood and EKG changes, things of that nature. We had done the initial work, surveying the clinicians to go back, look at their medical records, make sure people really had psoriasis when those codes were there. And so we conducted a study, an observational study in over 100,000 patients with psoriasis. We tried to infer or guess what their level of severity was based on what treatments they received. So, people with more severe psoriasis, they may get pills by mouth or light treatment, or they may just get topical medications if it's more mild. And what we were able to show in this very large population setting is that as people's disease got more severe, they had higher risk of heart attack, stroke, even cardiovascular mortality. It was often independent.
Just for the audience, the cardiovascular mortality piece means death from a heart attack or a
death
stroke.
From a heart attack or stroke. And ultimately, people with more severe psoriasis, moderate severe psoriasis, they die about 5 years younger than they should based on their risk factors for mortality.
And when you say that, you mean like controlling for all the things we would typically associate with heart disease, like smoking and alcoholism and obesity status.
Exactly right.
So when you take those out.
There's still excess mortality we can't explain based on all the data that the clinicians and the general practitioners have access to, which is obviously a lot of information.
Yeah.
So that was a pretty powerful finding. The first landmark paper we published was in JAMA in 2006. And when I published that, when you're doing science, you don't know if you're right until other people replicate your work.
Yeah.
Right. So this is a sort of a first finding of this scale and magnitude in terms of the type of study we were doing, and you just don't know if it's real until other people do additional studies to try and confirm it. And that's basically what's happened. Of all the inflammatory diseases out there, Crohn's disease, rheumatoid arthritis, there's probably the most data linking psoriasis to cardiovascular disease compared to all the other conditions out there. So much so that now the American College of Cardiology, American Heart Association, they recognize psoriasis as a disease that is a cardiovascular risk enhancer. And they also recognize that people with psoriasis have metabolic issues. They tend to have more challenge with their weight, more issues with insulin resistance, with diabetes, with elevated blood fats and triglycerides. So there's really a dual hit that people with psoriasis deal with. One is issues with body weight and insulin resistance that ultimately leads to more diabetes. And two is probably increased inflammation and other effects that drive atherosclerotic disease and cardiovascular events.
Yeah. The way that I have these conversations with my patients has always been, we can see the plaques on your skin, and the inflammation that's inside driving those plaques is the same inflammation in your body that is driving the plaques to form inside your coronary vessels and your
I think there's a very powerful thing about dermatology. And when I talk to my patients about this, they sort of get it. They say, I look at my skin, I see all this inflammation all over my body. Maybe I have inflammation, inside that's going on as well, and that's exactly the truth of what's happening here. And we've shown in a number of studies that as the body surface area affected by psoriasis goes up, so too does the risk of cardiovascular events, heart attack, stroke, diabetes. Often, even controlling for smoking and other health issues that are going on. In Sweden, they confirmed the same finding too, looking at what's called a PASI, a measure of how severe psoriasis in the skin, found the exact same findings. And so that's a powerful tool for people living with psoriatic disease. Most of us, let's say we have elevated cholesterol, people feel totally fine, or even with high blood pressure, people may feel totally fine.
Yeah. That's
why it's so important to get screened for these things. Yeah. The advantage of dermatologic illnesses is that the pathology is there for people to see, right? Yeah. So, if you're listening to this podcast, and you have psoriasis, that's a signal that something else may be going on.
Yeah. And it doesn't necessarily mean you have heart disease, but it does necessarily mean you are at an increased risk for heart disease.
That's exactly right. And what's so powerful about this association is that we know how to lower the risk of heart disease. Yeah. Okay, certainly treating cardiovascular risk factors, lowering cholesterol, lowering blood pressure, treating diabetes. It's there. These are the critical things. Quitting smoking, having a healthier diet. We've done some work recently showing that the Mediterranean diet, which is a diet rich in fatty fish like salmon, a lot of olive oil, a lot of nuts like walnuts, things of that nature, that those people not only have a lower risk of having cardiovascular disease or heart attacks and strokes and diabetes, it actually, in a controlled clinical trial we just did with colleagues in Spain, reduces the severity of psoriasis.
Psoriasis, right. It improves their ability to treat their psoriasis if they have it, or just reduces their likelihood of getting psoriasis.
It just shows you how holistic we all are, right? Our skin and our blood vessels and our ability to metabolize glucose and things of that nature, they're all related to one another.
Yeah, they're intertwined. This takes me actually to a question I wanted to ask you. You're very, very, very knowledgeable about this interconnectivity between our skin and our cardiovascular risks as it pertains to psoriasis inflammation specifically. Are there any other end organs that you think are worthy of noting that might also be at increased risk in those with psoriasis?
People with psoriasis have a lot of other health issues that go on with their disease. One of the more common ones is psoriatic arthritis, inflammatory arthritis. People wake up in the morning, they feel swollen and stiff, takes them a while to get moving. And oftentimes the first time a patient realizes they really have psoriatic arthritis is when they go on one of our medications for psoriasis, either a pill by mouth or an injectable medication called a biologic that happens to also treat the joints. Yeah. And what they'll tell me is that, I suddenly feel 10 years younger, doc. Yeah. I didn't realize that I was having these joint issues. Right. So that's a big one people need to know about.
I was having this conversation actually today with a patient of mine who wasn't sure if he was just quote unquote getting old or if this was, getting old plus probably having psoriatic arthritis. And we talked about the differential and how to determine which might be what. But ultimately, I mean, how many times have you had a patient come back and go, oh my gosh, I thought I was just old?
We've made so much progress in medicine. The ability to diagnose psoriatic arthritis is one place things have lagged. And what people need to know if you're living with psoriasis or psoriatic disease is that it's really a diagnosis of exclusion, meaning we say, okay, well, the joint symptoms are not from rheumatoid arthritis, it's not from osteoarthritis or other forms of arthritis, so we think it's psoriatic arthritis. And a rheumatologist could often do exam findings that make them feel more convinced that it's psoriatic arthritis. But sometimes we just got to try a treatment.
Yeah.
And because you don't often know, well, maybe the joint pain is from osteoarthritis or other issues going on, and then you try a treatment that really improves people's well-being quite a bit. The other major thing people should look out for is the emotional burden of dealing with psoriatic disease. So things like anxiety and depression, challenges with stress, very common in people with psoriatic disease. And so those are the big ones to be aware of, I would say.
UCB places the patient at the center of everything they do, creating value for patients now and into the future. They are trailblazers in the immunology space, conducting cutting-edge research and designing and running bold clinical trials. Yeah, no, and this is very, very helpful. I think, again, as we kind of talk about our skin as an interface to the environment and to the world in which people are living every day, that stigma is something that carries a tremendous weight, and the emotional burden of that is something that we can't underestimate.
I think that patients will often tell us that stressful life events triggered their psoriasis. Mm-hmm. One of my favorite studies was done by an Italian dermatologist, epidemiologist, Luigi Naldi, many years ago. And what he showed in Italy is that people who had major stressful life events, a death of a spouse, a divorce, or something like that, they had a much higher risk of developing psoriasis than people who didn't have those major events. And I remember one patient that was very striking to me. She was in her mid-80s when she first developed severe psoriasis. So imagine you've lived your entire life, you're in her 80s, and her sister had died. She was very close with her, and she was taking care of her husband who was ailing from cancer too. She was under an enormous amount of stress, and this triggered severe psoriasis in her. And the mind-body connection is so clear in people with psoriasis in terms of trying to understand it. One of my other favorite studies is by a guy named John Kabat-Zinn, who's well known for sort of bringing mindfulness meditation to the United States. And he did a study years ago where he showed that people who were getting treated for psoriasis with ultraviolet light treatment, that some of them would listen to meditation tapes and some would be randomized as to listen to regular music. And those who were trained to do meditation, their skin cleared faster than those who were just listening to music.
Wow.
Right. And so this is something I often talk with my patients too, thinking about stress management with mindfulness practices, meditation being one of the ones better shown to be helpful for people. It's another part of the puzzle, right? So thinking about this disease holistically, not just about the skin itself, but our central nervous system, how we respond to stress, as well as our cardiovascular system, our musculoskeletal system.
Yeah. We're all one very complicated machine is really what we're saying. And it's awesome to know. I didn't actually know about that trial that you had said was published regarding meditation. But it's not surprising. When patients are undergoing stress, we see, their psoriasis get worse. And we know, too, when they can do something better to deal with their stress, they often have an easier time of treating their disease. So I want to ask you, I think one of the major outstanding questions, and probably to some extent a major outstanding question that still lends itself towards needing additional data as far as I'm concerned. But I really want to know your take on, well, okay, then what happens when we actually treat psoriasis effectively? And those, I call it the psoriatic diathesis, sort of the scope of inflammation that drives the disease, both on the skin and in the joints and in other organ systems like the cardiovascular system. When we are adequately treating psoriasis, so we can visually see someone's psoriasis improving substantially, are we also modifying their cardiovascular risk?
So this is a critical question that we haven't answered definitively yet. Most of the data we have available is what's called observational data. The patient decide to go on one of these therapies or decide not to go on the therapy, one on something different. Those studies, generally speaking, show benefits, that people who could control their psoriasis or on systemic agents, particularly biologics, they tend to have lower rates of cardiovascular disease compared to people who are not being treated with those therapies.
And that's amazing, right? Here we are. Physicians, many times even just in the public realm, thought of as, surface doctors, and maybe we handle pimples. But really what you're just saying is you can reduce someone's risk of heart attack, stroke, death from heart attack or stroke by recognizing psoriasis and treating it adequately in very simple terms.
I'm going to put a maybe on that.
Yeah, no, okay. Of course.
But so here's the thing. So I think what's really important for our listeners to know about is that ultimately with physicians, when we're making decisions with patients, we want the best level of evidence. We want certainty to know that if I do A, this is going to change your likelihood of having this health event. So we really need randomized controlled trials for that. And the challenge with observational data in this setting is that there's a strong healthy user effect in people with psoriasis. People who tend to go on these systemic agents tend to be healthier than those who don't, which probably should be a message to those out there who are dealing with a lot of other health issues and saying, my skin, I don't care about, let that go, I'm more worried about other things. We're not sure that's a good idea. It's probably better to try and control inflammation in the skin. And
in experiential medicine, and we're practicing this every day, you see, too, that other disorders become more easy to control when you've controlled the inflammation of psoriasis.
That seems to be the case. But certainly we also know when we control people's psoriasis, they're just happier.
Oh, yeah.
They're more productive on money levels. And most of my patients who have been very reluctant to treat their psoriasis, we've sort of talked about for years, they finally decide to go on a therapy that's going to be effective. Invariably they'll tell me that they wish I did it sooner.
Yeah.
That they didn't realize what changes they made to their life to accommodate their psoriasis. They stopped doing activities where it was hot outside because they didn't want to wear shorts. Or things
go swimming with their grandkids.
Exactly. Yeah. So these things make a huge difference in people's lives when you have the opportunity to do it. But I would say that, so while the jury's still out about whether or not treating psoriasis directly impacts cardiovascular risk, what we know we do need to do is identify cardiovascular risk factors in people with psoriasis and treat them adequately. And here's where we have a big gap going on. For reasons we don't fully understand, patients with psoriasis tend to be less likely to get diagnosed with cardiovascular risk factors. They're underdiagnosed, I would say, compared to the general population. And they tend to be undertreated, meaning that if one person has psoriasis and the other person doesn't, and they both have high blood pressure, the person with psoriasis is less likely to have their blood pressure adequately managed. Okay. And we don't know if that's because maybe the treatments for blood pressure don't work as well in people with psoriasis and hypertension. or if they're not being treated aggressively enough for that blood pressure. We just don't know exactly what's going on there. But what we do know is that that's a solvable issue, right? That we could, patients now know that they have a higher risk of heart disease related to their skin. That's a signal to go into your primary care doctor or your dermatologist, whoever takes care of you, and check your blood pressure. Check your blood glucose, something we call a hemoglobin A1C, which will tell you, how your body's handling blood sugar over the last 3 months or so, and check your cholesterol, right? And if they're abnormal, there's diet and exercise that can be tried, and obviously very effective medications as well.
So I want to circle back to the actual numbers real quick for the audience, because we're talking about risks, and I want to make sure they really understand the consequential nature of these risks. So we're not talking, very modest or marginal, deltas or changes between the general population that doesn't have psoriasis and their cardiovascular risk versus those that do. Tell me a little bit about your work in uncovering what that risk change really looks like.
Well, what's tricky about cardiovascular disease is that the risk of having a heart attack or a stroke in a year is always going to be low for anyone, right? It's that cumulative risk over years, over 10 years, even over decades that we really think about, right? So most people do not want to have a heart attack or a stroke in their 50s or 60s. They want to live a full, healthy life. And so that's sort of the way to think about this. All cardiovascular risk factors sort of behave that way. High blood pressure, high cholesterol, none of them have an enormous short-term risk of having a cardiovascular event, but it's cumulative over time.
Right.
And that's why it's so important to address these issues, early on in the course. It's sort of like the idea that, if you're a ship on the ocean and you're only off by 1 degree, after a year, you don't notice that you're any different. 3 years, maybe you don't notice you're any different. 10 years, you're like, I'm a little off here. And then you keep on going, you can be kind of lost, And so it's similar things with our health, which is that there's a number of major health indicators, whether it be trying to maintain a healthy body weight or having a healthy diet, or maintaining our blood pressure or cholesterol well controlled, or having our skin inflammation controlled. These are things we have to do over time and maintain them over time. It's not there's no quick fix here, no quick bullet.
No. But it is fascinating to note that, if you're someone that's struck with significant psoriasis, what we would call moderate or severe psoriasis, meaning a lot of the body surface covered in psoriasis at an earlier age, that perpetual abundance of inflammation driving that disease does increase the risk substantially, even as early as one in their 30s or 40s. And granted, the overall absolute risk remains low, but substantially greater than those without psoriasis.
And what we've learned in recent years through some new genetic type studies, where basically they look at people who inherit certain genes that we know cause certain health problems. And a new set of studies suggests that people inherit genes that make them prone to developing atherosclerosis, hardening of the arteries, cardiovascular disease, that they develop psoriasis at higher rates than people who don't have those genes. And so the way to think about that also is that the relationship maybe go in both directions here, right? That having chronic inflammation in the skin can trigger atherosclerosis, but actually having atherosclerosis could trigger inflammation in the skin.
Well, and what we've learned, in my quote-unquote short year of 20 years now in dermatology, is that disease of psoriasis that we used to think, okay, well, it's just the skin proliferating, getting thick and scaly. Well, okay, then we learned it was actually inflammation driving the proliferation of the skin, getting thick and scaly. And then subsequently, we have now recognized that those skin cells that are replicating, that are becoming thicker and thicker and thicker, are actually also biologically active cells that are driving the inflammatory process itself.
There's a lot of interesting data out there. One study by a guy named Rich Gallo, who's a premier basic scientist, dermatologist in our field. He basically showed that that cathelicidins, these things made by the skin in people with psoriasis, actually can circulate and impact how cholesterol is handled in the blood. That makes cholesterol more dangerous.
Yeah.
Right? So who would ever make that link, right? That somehow the skin is making a protein that somehow affects how what's called LDL, the so-called bad cholesterol, makes it worse. That's another remarkable connection between the skin and cholesterol and atherosclerosis that you would not have thought about without the research that's been going on.
And exactly why I brought you here, so that the public has an opportunity to realize that these connections and the interconnectedness of what's happening on our skin and what's going on the inside are just so overwhelmingly real.
I think that we live in an incredible period in medicine now where our knowledge base is expanding so rapidly. Our ability to help people with novel therapies expanding dramatically. Anyone who's sort of listening to this, I would encourage them. A lot of people with psoriasis have been dealing with it for a long time, and they may have been through a period of their life where they're like, the doctors don't have anything to offer me. That's changed dramatically now.
It's time to circle back to their dermatologist.
Time to circle back. We have new topical medications. We have new ways of delivering ultraviolet light. We have new oral medications, new injectable medications. For almost any patient, we could find the right therapy for them that's going to give them relief from their psoriatic disease.
Yeah. And I know that we're going to, pivot a little bit with this question, but I think it's worthwhile. You've been doing recent new research, partnering with, I think, another country's research group, looking at GLPs and what exactly is happening there. We know GLPs are offering our patients with obesity a diminution, obviously, in weight, the treatment of their obesity primarily, but also a reduction in the inflammation that is carried by those that are obese, that the visceral fat cells are...
This is a very interesting story. So, it was first recognized decades ago, actually in World War II, when people who had psoriasis and were in concentration camps during the Holocaust, when they were undergoing terrible starvation periods, their psoriasis would go away. And in more modern times, people recognize, if you put someone on a low-calorie diet, their psoriasis would get better compared to a regular diet. Just losing weight seemed to help psoriasis a little bit. That's obviously really hard to do. It's hard to lose weight, which is part of the reason why these medications called GLP-1 receptor agonists, GLP-1 RAs, why they've become such powerful medications in society, because most people have tried to lose weight when they're dealing with that problem. And it's very difficult. It's probably genetically mediated.
Right. And I really want to call it, it's not just a discipline problem. I mean, our patients are many times already predisposed to an abnormal metabolic processing.
That's exactly right. And I think people know this inherently. Some people say, now what I do, I'll gain weight. Another person, the same food, they don't gain weight, right? So that's a real challenge that some people have to deal with. And we were very interested in how these GLP-1 medications may help people with psoriasis, because we know that weight loss could improve psoriasis, and these medications consistently help people lose about 20% of their body weight over a year. But then the question was, would it actually have some direct effects on psoriasis? And this is where the story gets very interesting. So one of my colleagues, Johan Good-Johnson, he's at University of Michigan. He's a premier basic scientist and dermatologist also. He's shown that the GLP-1 receptors are actually present on regulatory T cells in the skin of people with psoriasis. So the cells that are telling the immune system to be active or not active in the skin actually they actually express receptors for GLP-1. And then we know from other work that when people take GLP-1 medications, that it lowers inflammation in their blood that's related to psoriasis, cytokines that we try to target to try and treat psoriasis. And then the most recent finding, it comes from my group. This is work led by Ravi Ramaswamy, who's a postdoc from the United Kingdom. He's in my lab this year. He does genetic work. And similar I mentioned earlier about, people who inherit genes that make them more likely to develop heart disease, that they develop psoriasis. He did the same experiment where he looked at people who inherit genes that make it as if they're taking a GLP-1 agonist. And
so they're genetically protected. They're sort of protected against obesity genetically.
Well, this is what you find out in those patients. People who have the genetics that increased signaling of GLP-1 in their body just normally, they are less likely to become overweight, less likely to develop diabetes. Turns out they're less likely to develop psoriasis and psoriatic arthritis. And on top of that, it's a specific finding. When we looked at other inflammatory diseases, eczema or atopic dermatitis in the skin or acne, or inflammation in the gut like Crohn's disease, ulcerative colitis, or inflammation in the joints like rheumatoid arthritis, we didn't see any effect there, right?
So those patients with the gene that sort of confers protection for obesity, diabetes, and psoriasis, that same gene does not confer the same protection against Crohn's disease, ulcerative colitis.
Exactly, right.
Interesting.
So it tells you there's something very unique and specific about the relationship between metabolic disease, insulin resistance, being overweight, and developing psoriasis. Yeah. And we knew this from observational studies before that people who were heavier or gaining weight, that if you follow them over time, they're more likely to develop psoriasis and psoriatic arthritis. But this is now sort of genetic evidence that is, it's some people think it's like a randomized controlled trial, like I alluded to earlier. That it's a true causal effect because we inherit our genes sort of randomly from our parents. And so the fact that people who inherit genes that make it as if they're taking a GLP-1 medication don't develop psoriasis, psoriatic arthritis as much, and that you don't see that for other diseases is pretty powerful evidence. Yeah. And so one of the things we're hoping to do is clinical trials as monotherapy. Just to take a patient who has psoriasis, who's overweight or has a BMI 30 or higher, and we would say, well, let's try a GLP-1 medication compared to placebo and see if that makes the psoriasis better.
Right.
And that may flip the script a little bit. There may be some patients out there who could go on GLP-1 agonists, and that may be enough to improve their skin disease enough that they don't need systemic agents.
Well, and mind you, also probably lower their cardiovascular risk, their obesity status, their sleep apnea.
Certainly. We know these medications have had tremendous general health benefits for patients. Yeah. And there is some evidence that suggests this is the case. One of the drugs, tirzepatide, the brand name for people who are overweight is called Zepbound. They did a clinical trial in people with psoriatic arthritis and showed that those randomized to Zepbound, everyone was getting a biologic for their psoriatic arthritis, a drug called ixekizumab or Taltz. That those who were randomized to the GLP-1 agonist, tirzepatide, their joints got better than those just getting treated with a psoriatic arthritis medication alone, right?
We actually did the trial for psoriasis patients, not psoriatic arthritis, and we are also looking at data that looks overwhelmingly promising that when you give patients combination, you're not only getting enhanced weight loss, but they're also getting a significant reduction in the severity of psoriasis.
It's a powerful reminder for people living with psoriatic disease and those of us who take care of them of the importance of being holistic about it, right? And we talked a little bit earlier about, that the risks in a short term may be small, but over time, accumulate over time. It's likely the same thing with psoriatic disease. Controlling all of their health issues, particularly body weight, to make it a healthier body weight range, likely makes psoriasis milder over time, easier to control over time, less psoriatic arthritis over time. But we don't have the data to prove that quite yet. But certainly everything we understand about how these diseases interact with each other suggests that there's a good reason if you're dealing with being overweight and psoriasis to address both of these conditions.
Yeah. And I think we also would probably agree that many of our patients that have psoriasis, it's not unusual to be looking at a patient with psoriasis that has a BMI that's 30 or greater. And when you look at the clinical trials for all the phenomenal drugs that we have now at controlling for inflammation and psoriasis, again, you mentioned pills and injectables, that when you look at the mean, the average BMI in those patient populations.
Right. And I think what people who are living with body weight challenges and psoriasis, what they need to know is that genetics plays a role here too. Like we know from similar types of studies that I mentioned that Ravi Ramaswamy did, is that people inherit genes that make it harder to lose weight. They develop psoriasis at higher rates, right? So there may be something about living with metabolic conditions, insulin resistance, being overweight, having psoriasis. This means the genetic cards are stacked against you. And certainly we encourage exercise and a healthy eating and things of that nature. We mentioned the Mediterranean diet earlier. But for some patients, that's just not going to be enough.
Right. I ask my patients to control for the factors that they can control for, which are don't smoke, don't drink excessively, eat a good diet, exercise regularly, meditate if they can. And yet, you know what? We're going to just readily admit that this may not be something that you can control with your lifestyle modifications. Yeah, this is fascinating. I have to just call out to the audience that we're talking now in 2026. This is 20 years after Joel Gelfand brought us this novel, gangbuster article in JAMA, really explaining how it appeared that psoriasis was giving our patients and us an image of what otherwise was going on inside their heart. Inside their blood vessels, feeding their heart, their coronary vessels, putting them at risk for, and I'm totally butchering this, we're going to cut this real quick, but the name of the article was systemic inflammation.
No, it was risk of myocardial infarction. The risk of myocardial infarction people with psoriasis.
Bringing us this incredible novelty at the time in the article published in JAMA 20 years ago in 2006, psoriasis and the risk of cardiovascular mortality.
Risk of myocardial infarction.
Okay.
Risk of heart attack.
Of psoriasis and risk of myocardial infarction, which is a heart attack. we're talking 20 years later about this, and I think at that time, I would just love to have gone back into your brain and said, did you have any idea how game-changing this was going to be? I mean, I know you said you got to have like other people, replicate what your findings are in order for it to be truly understood and scientifically validated. But could you even contemplate that this was going to be so game-changing?
One of the things that was interesting about that experience is that when we published that finding, it got a lot of press coverage. I was on national news, TV appearances on news programs, and the National Psoriasis Foundation told me it was the most attention they had ever gotten for psoriasis in their decades of experience of trying to advocate for people with psoriatic disease. I think that some people may be listening to this and say, we've known this for 20 years. How come I'm just hearing about this now? This is one of the challenges in healthcare. It often takes a long time for new knowledge to make it into clinical practice, to change what we do to help people. And certainly now, our guidelines really call for educating patients about this relationship, screening for traditional cardiovascular risk factors, treating them, aggressively when it comes down to it. We want that cholesterol, lower. We want the blood pressure well controlled. We want to make sure that they don't have diabetes, or they do. It's being controlled. We have more to learn.
Yeah, well, and you're still spearheading this work, which is just tremendous. You speak to my heart when we talk about how skin gives us this signal and sign of what otherwise is going on inside. So I'm going to ask you kind of some rapid fire questions because we're going to have to come to conclusion.
Let's do it.
But this has been incredibly fun. All right, so rapid fire, Dr. Joel Gelfand.
Yes.
Psoriasis, skin disease or systemic disease?
Good one. Systemic inflammatory disease, yes.
Biggest myth about psoriasis?
That's not a serious disease.
One number every patient should know?
It's got to be more than one. You have to know your cholesterol. You have to know your blood pressure. You have to know your hemoglobin A1C if you have psoriasis. But you also have to know how much disease bothers you and communicate that to your clinician. I think too many patients feel alone with their disease and all that it entails, and they're reluctant to share their burden either with their family members or their friends or their clinicians, a dermatologist.
Oh, I think that they've also oftentimes lived a life of trying to hide their disease. So all of a sudden to strip naked in front of someone and display to them what this is and what it's meant to you, it's not easy.
It can be very stigmatizing and challenging for patients, and many people living with psoriasis feel like they've been blown off by their doctors over time. It's not serious. It's just a skin disease. Get used to it.
Okay, so next rapid fire question. What is one thing you would ask dermatologists not to ignore?
I would ask my colleagues, don't ignore cardiovascular risk in psoriasis. This is an easy thing to deal with patients. It's easy to screen for these risk factors. And, when we talk to patients, they expect us, we wear a white coat, we are doctors, they expect us to do these screenings for them. They value our advice when we talk about cardiovascular risk in the context of their psoriatic disease. And it's a very gratifying way to help patients.
Yeah. So closing, I want to say thank you so much. You gave a message to your dermatologist. I'm going to ask for one last message to the public who's listening today. If there's one thing you want to leave them with as a message, what would you like to say?
Hope. I mean, there's a lot of hope for people with psoriasis. It's a tough disease to live with, but of all the inflammatory diseases out there, we probably have made the most progress in psoriasis with the most advances in therapies. And most people out there, we really should be able to get their disease clear, completely clear.
Yeah, I love it. We have a little sign on the inside of our door walking into the house from the garage that my son made when he was in kindergarten, very artistic, and it just says, keep trying.
Yeah,
and I have to say thank you so much for always continuing to try to bring us novel information, new, meaningful information, data that's going to be still yet game-changing in the way we approach our patients. And really, for all of you listening today, I hope you have found this to be tremendously meaningful. Joel Gelfand, this has just been absolutely my pleasure to have you here today. Thank you for sharing all of your knowledge and wisdom. I hope everyone got as much out of this as I did. I appreciate you being with me. Thank you.
My pleasure, Lindsay. It was great.
Don't forget to subscribe, rate, and share this episode of Dermatology Undressed, a provocative podcast. Until next time, stay curious, stay kind, and keep peeling back the layers. When the skin speaks, it's never just skin deep. This is Dermatology Undressed.